Welcome to Grand Rounds today. My name is Aditya Lati. I'm one of the directors of the Grand Rounds series, along with Dr. Alex Harris and Rebecca Mueller. Next week's Grand Round will be given by Dr. Connor Liston, Professor of Neuroscience and Psychiatry at Weill Medical College. The topic of his talk is Probing and Rescuing Dysfunctional Brain Circuits in Depression. This talk will be in person with a Zoom option for those who wish to. Today, we have a very special Grand Rounds that's sponsored by the Office of Equity, Diversity, and Inclusion, and is also part of our Columbia Celebrates Diversity event. We'd like to welcome all our psychiatry resident applicants who are joining us remotely today. Welcome. Before we introduce today's speaker, I just want to give you a few house informations. We encourage everyone who's joining us to ask questions. You could do so during the talk. You don't have to wait till the end. Please use the Q&A feature rather than the chat feature to ask your question. We also particularly would like to welcome trainee questions, so please indicate the word trainee in your question, if appropriate. Finally, if you'd like to ask the question yourself live, please let us know, and we will promote you temporarily to panelists so that you may do so. Okay, so use the Q&A feature, indicate if you're a trainee, and indicate if you'd like to ask the question yourself. So today we have a special Grand Rounds, as I mentioned, and to introduce the speaker, I'd like to invite Dr. Jayan Miller, who's an assistant professor of systems neuroscience here at NISP, to introduce our speaker. She will also be directing and moderating the Q&A session that'll follow after this. So, Jayan.
Thank you, Adi. Good morning, everyone. My name is Jayan Miller. It is my honor to introduce Dr. Lisa Fortuna for today's Grand Rounds. Dr. Fortuna is professor and chair of the Department of Psychiatry and Neurosciences at the University of California, Riverside School of Medicine. She is a child and adolescent psychiatrist, psychiatry department leader, and health services researcher with expertise in implementation and health services research, focused on improving access to healthcare services by traditional underserved populations. Her area of clinical focus for the past over 20 years has been the delivery of care for culturally diverse populations, including providing immigrant and refugee specialty care for children and adolescents and adults. She has studied the mental health effects of climate-related forced migration for children and young adults, and multi-level sequelae of disasters and forced displacement such as Hurricane Maria in Puerto Rico. She has been an investigator on national and international research funded by the NIH, foundation-funded epidemiological studies, innovative models for addressing mental health care and substance use disorder services disparities, and prevention interventions for migrant and youth of color. Today, we are honored to have Dr. Fortuna talking about the From Stigma to Strength, exploring the role of discrimination and belonging in mental health research. As we go along, please put your questions in Q&A so we can have vibrant Q&A session at the end. Lisa, thank you. Thank you for coming.
Thank you so much. It's a pleasure to be here. And I will share my screen now, and hopefully you see that. Okay. Yeah, so I want to definitely talk about depression and trauma, and also looking at social inequities, and with a focus on cultural trauma for communities, and really want to talk about partnered solutions as well. So some of the disclosures, no conflicts of interest, and I will be talking about research that has been funded by the NIMH. And there's some artwork throughout the presentation that are youth muralists, primarily from the Mission District in San Francisco, where I was last working. So after this presentation, just to talk a little bit about what some of my objectives are today, is to, and hopefully after the presentation, you'll be able to think about how to describe the interplay of cultural trauma and discrimination in mental health and things like belonging, on mental health outcomes and relevant conceptual models, and then apply those to understanding how findings from community participatory research can be applied to clinical practice and ongoing research, and consider the opportunities in using new technologies in addressing mental health disparities that integrate some of these ideas. So, unfortunately, I've been starting a lot of presentations and thinking about children and what really has been the impact over the last decades of both the pandemic as well as health disparities in mental health services. What we know, at least from data, and this is primarily data from California, but it's not uncommon statistics. 81% of children on Medicaid or Medi-Cal in California are non-white. 2 times the rate of suicide in Black children, ages 5 to 12, is something that we have actually seen nationally. And 70% of youth in California's juvenile justice system have unmet behavioral health needs. And so a lot of the work that I've been doing and colleagues in health services and health disparities research is really identifying that we need to shift the paradigm. We really need to develop healing-centered care that isn't simply a matter of tweaking access to programs or tweaking the programs themselves, but it really requires an acknowledgement of the role of racialized stress and poverty and cultural trauma and other things that impact the social and emotional health of children, families, and frankly, their communities. So during the pandemic in 2020, myself and some colleagues, wrote this article that really looked at, what is behind the disproportionate disparities, right, around COVID-19 for youth of color and for communities of color. And we knew during the pandemic that there was a disproportionate impact on infections and fatality in Black, Latino, Native American communities. And it really became apparent to the general public, I think, that it was an imperative that our country focus and invest on getting at the root causes, right, of these health inequities, the social determinants, the structural determinants, which I'll talk about more, and to really work across sectors to build self-efficacy and long-term capacity with communities. And this is going to be a theme that I'm really going to drill down into the importance of working with communities and within systems and across systems to really address the underlying roots of the disparities that became very apparent in the COVID-19 epidemic. So a little bit of this framing. So this is from Dr. Sobika and Link, who are actually here at the University of California, Riverside, and colleagues, that I think their model of cultural trauma and cultural disparities really is one that I think helps to frame what I'll be talking about and the research that I have been doing for quite a while. We've heard a lot about structural determinants of health and social determinants of health, and I'll define those a little bit more in a minute. But I think this model really helps frame the things that I have been seeing in my research, and also things that can point us to places of intervention and change. So what this model is really saying in a nutshell is that living within a dominant group, a dominant culture, and dominant power structure, there are multiple replaceable mechanisms, unfortunately, multiple ways that communities, minoritized communities, experience cultural trauma. And that includes the reduction of cultural resources through policies and structural issues that that actually remove cultural resources from communities or block them from having access to those cultural resources, institutions, even lands, if we think about the Native American community. And this really starts impacting in several ways, including minority stress, an increase in stigma, decrease in cultural resources and cultural wounding, and then also actual wealth disparities and a decrease in flexible resources like money, power, prestige, voice. And all of these things are part of the contributors to health disparities, besides also being things that directly impact on an individual's mental health, well-being, and social well-being. And so that framework, I think, fits very well in a lot of the research, again, that I've been doing over a long period of time. So these are the following studies are just examples of how I think we can look at this. So if we look at really social, cultural, and ecological factors that really impact on mental health of communities, for example, immigrant communities, I think we can identify some important factors that might be important for intervention design. So if we look at, for example, acculturative and immigration stressors, that has been an area of research for me for quite a while, is, even when we were looking at a national database. So the first study there, Fortuna et al. 2018, is actually a study that we did with immigrants, that immigrant adults in primary care. And the study was actually conducted in Spain and in the United States. And we looked at serious suicidal ideation, thoughts of killing oneself in the last month in an immigrant population. And what we found was individuals who, and we'll see a little bit more data from that in a moment, but what we found was that individuals who felt like they did not belong in the United States, culturally, socially, economically, and also start to have a decrease in sense of belonging in their country of origin, that was a factor, even when adjusting and considering mental health disorder, that belonging was a risk factor for serious suicidal ideation. And in addition, even prior to that, in a national database, a national Latino and Asian American study, we looked at family conflict and other social cultural factors that impacted on suicidal ideation in this nationally representative database, and also found that things like family conflict, higher level of acculturation, and loss of ethnic identity were related directly to suicidal ideation. And then the other thing that we have seen over time, which I'll show some data on, is that over generations, there is an increased experience, sense of awareness of everyday experiences of discrimination, and that's related to depression. So those are some of the things that we can think about in that cultural model, Subika and Link, that I described earlier. And then even before that, we did a lot of research. This is research that I did with Dr. Luis Zayas in New York when he was in Fordham, where we really looked at the increased rate of suicidal ideation in Latina teens that was very apparent across several national studies and school-based surveys. And we developed this model where, again, we were looking at how the family's social cultural environment in terms of culture and cultural traditions and stressors on that in combination with adolescent development, the health of the family functioning, how that could contribute to a youth's family emotional vulnerability, psychosocial functioning. And then when there is a subjective experience of adolescent family crisis, for example, arguments and fights about gender roles, that can really relate to suicide attempts. And this was a model that we developed through several surveys and qualitative mixed method studies, where we really saw this interaction between social context, family context, culture, and stress on suicide attempts in Latina adolescents. And then this is a little bit more data on the prevalence and correlates of lifetime suicidal ideation attempts among Latino subgroups, again, in that national representative database, where this is where we saw the prevalence of suicidal ideation and attempts, 10.2 and 4.4 respectively. Puerto Ricans were more likely to report ideation as compared to other Latino groups, and that was one of the strengths of this particular national database, the National Latino and Asian American Study, that you could look at Latino subgroups, which further delineates the importance of really looking at specific cultural contexts, specific ways that these sort of social and cultural and structural issues might impact communities differently. What was found, though, with the Puerto Ricans is that the difference between Puerto Ricans and other Latino groups was eliminated after you adjusted for psychiatric and social cultural factors. Having a psychiatric diagnosis obviously adjusted it, but then also social cultural factors like degree of acculturation and family conflict. When you adjusted for that, some of that related. And that really, we thought that related to, Puerto Ricans being more acculturated, being here in the United States longer, and that relating to higher degrees of suicidal ideation, and then female gender. And this just looks a little bit closer at that study that I mentioned earlier around immigration stressors and looking at the sense of belonging in the sample that was in Spain and the United States. And again, sort of higher, degrees of sense of discrimination was related to suicidal ideation, lower ethnic identity, family conflict came up again in this study as an indicator of increased suicidal ideation, as well as obviously diagnoses. And the other thing was if you were a non-citizen and you had the stressors of not having that citizenship, that was also related to increased suicidal ideation. So again, this is looking at a lot of cultural and social determinants, right, of mental health. In childhood trauma, this is another study, and I'm featuring here my colleague, Dr. Michelle Porsche, who I've done a lot of this work together with. And in this particular study, again, looking at the National Latino and Asian American study, we were looking at, the relationship between childhood trauma and correlates of school dropout. And what we found was that when youth had a history, when the study survey respondents said that they, had an indication of childhood trauma, that if they also had a diagnosis history, lifetime history of substance use, that combination of that pathway of childhood trauma and substance use, or having had a diagnosis of what at that time when they were youth was conduct disorder, meeting criteria for conduct disorder based on history, that combination of things was related to dropout. And again, we can think about how youth with trauma may have unmet needs that then result in substance use, and also result in sort of behavioral problems that are determined as conduct disorder, and that combination really resulting in youth dropping out or being pushed out is what one of our hypotheses was, out of high school and school, and sort of just further determines the outcomes and the longitudinal resources and outcomes for youth. And then digging in a little bit deeper into this idea of experiences of discrimination. Again, at that National Latino and Asian American study, we looked at how who in the sample was reporting more experiences of discrimination. And what we found at that time was that more men than women, and this is again the Latino sample of the National Latino and Asian American study, more men than women reported discrimination. Younger Latinos were significantly more likely than older Latinos to report daily experiences of discrimination by almost a linear relationship, as you can see. here in the graphic. Unmarried Latinos more so than married Latinos, and those with more education, and those with higher incomes. So this was an interesting sort of thing, that those with more education were more likely to experience that. And again, we looked at this in terms of how people over time and with acculturation have more and more interactions with systems where they might be experiencing that degree of discrimination, and also increased awareness, right, and interaction with the host dominant culture, right, which we were talking about in the cultural model, right? So there's more experiences of that, and more sort of awareness of losses related to that experiences of discrimination socially. So that is, a little bit of a history of a lot of things that I've looked at. And when we think about how do we shift a paradigm shift, right, in terms of what we do as psychiatrists, as psychologists, as mental health professionals, as health professionals, in thinking about all of these sort of larger social and systemic drivers of our patients' health outcomes. And I really appreciate this quote from Helena Hansen, a colleague here in Southern California, current professor and chair at UCLA, where, this quote from their recent paper where they say the leading reason offered for burnout involved providers' inability to address the social and systemic drivers of their patients' health outcomes. For psychiatry to survive as a profession, to attract and retain practitioners, psychiatrists must be enabled to intervene on social and systemic drivers of their patients' health. All of these factors, and then some that I've been describing in the studies. And that's a tall order, right? And so that's what I'm hoping to talk a little bit more about in terms of how do we, deepen sort of in our understanding of health equity frameworks, and then think about ways that we can actually make a difference in that. So, and that's where my research has gone, and my work has gone over the history of my career. Just a little bit of a review in terms of structural determinants. We know that those are the root causes of health inequities because they shape the quality of the social determinants of health experienced by people in their neighborhoods and communities. What are the resources in the communities? What are the lack of resources in the communities? What are those sort of cultural losses? And also, that the social determinants of health are really around the conditions and environments where people live and should ideally thrive. And that we really need to have some sociogenic approaches, which means, how do we really address those things that are socially produced, as opposed to trying to address things that are static or immutable. And so that's where I get to this idea of really how do we engage community-based participatory research that strives to understand how these different social, cultural, and structural factors impact on communities. And here's a quote from Barbara Israel, Methods for Community-Based Participatory Research, where she says it's critical that CBPR efforts strive to understand all those historical and contemporary social, economic, and environmental contexts that have a significant impact on communities, to work to improve those conditions and foster these health inequities. And it's essential that cultural contexts of communities be understood and respected, and explicitly informing partnership approaches to research that then can get us to some solutions. So here a mural from San Francisco. I said that I would intersperse some of those. And this one I particularly liked taking a photo of because it was a very large mural, and I can't show it all of it, but it had a lot of depiction of youth, of community members, of family members, of the community in its totality, being involved in the healing process and the care of the community. And this idea that culture and pulling back to our resources that historically communities have had, that is part of the healing process. And so to me, that only reinforced the importance of fostering really authentic partnerships with communities, as giving space to the power of thinking about the research and interventions that will develop as co-design partners. And one of the things that we did was colleagues and I, Dr. Michelle Porsche, helped lead in this article as well, where we were really trying to study as researchers, right? So it was Dr. Michelle Porsche, Dr. Marina Tula-Shams, and a couple of other colleagues that really began to do a reflective process about how were we really working with communities in being able to create change. And we used this methodology called duo ethnography, where it's a collaborative research methodology in which two or more researchers engage in a dialogue in writing in their disparate histories with a particular phenomenon. And here we were really looking at our research with communities in developing interventions. And we really wanted to interrogate and try to reconceptualize our beliefs about how we were doing this work through this written and play script format, where one would write and you would reflect in writing and others would be able to respond to that as well as create their own narrative about this process, right, of doing research with the community. And really, the aim was to see how that can contribute to a sense of personal change as researchers and explore how the researcher is suited socially and culturally in the work. And some of the questions we asked ourselves is, what have we learned about working collaboratively with community stakeholders working with youth and families? What does it mean for a researcher to authentically share leadership and design responsibilities with youth, families, or communities? How do we address power differentials in the exclusionary context that we're trained in, that is academic research, and I think even in medicine, right? And some of the things that we found in terms of doing content coding of this back and forth narrative was the realization that, you know, even though most of us who were doing this, I would say, you know, 4 out of 5 of us come from communities of color and underrepresented in medicine, we found that, you know, in the privileged investigator role, we were often in our research, when we were doing intervention development, simply asking for feedback and confirmation of our research questions, with little sharing of responsibility of the design of those studies and the interpretation of those studies. That we relied on our own technology expertise when we were doing, for example, digital interventions, that hampered the extent in which we tried to obtain community identification of both the problems and the solutions to all these you know, social and cultural and contextual issues that I've been talking about. And that, you know, this might seem very familiar to many. There was a big sense of a history of researchers dropping in to take from the community data, and that was met with skepticism and reasonable skepticism. And that we had to check our own views and be more intentional in incorporating cultural humility, even as researchers who come from cultural backgrounds that are minoritized, to start to examine whether and to what degree partners view, even if we're creating a digital intervention, like how much do they view the technology as the answer, and how might, you know, a particular intervention be of help or not. So very important. So that has been a very significant, I mean, I think that process of doing that study, even though it was something that I was reflecting on for a very long time, I think brought really prominently into mind the importance of trying to really dig into this collaborative, community-based participatory research approach. And we have been trying to implement that in our current study, which is a UO1 funded by NIMH, where I called the For Youth by Youth study, where we are trying to implement a digital intervention, a mobile technology that has mental health prevention and wellness tools and connections to social determinant of health supporting resources in English and Spanish, and to implement it in school-based and pediatric primary care services as ideal hubs for increasing access. And this research was a product of a proposal that was in response to NIH transforming health disparities. And it really was, the call for proposals was really focused on deep community participatory research. And what we've been implementing is participatory design and community partnered participatory research, where there is this intention for a high degree of including youth, their caregivers, and providers in really designing this intervention. It started off with, we started off with a intervention that was already beginning to be developed, which was the Connected for Schools app. And I'll talk a little bit more about that. These are investigators, calling out again, Dr. Michelle Porsche is there, and Shara Kateoka, my colleague at UCLA. And what we're trying to do is integrating this digital mental health technology and combining it with peer and community supports and resources in the schools and in the clinics, where it's not just only an app, but we're also integrating the importance of peer support champions, as well as family navigators, to help young people and their caregivers in their respective way integrate sort of their use of these resources. And I'll talk a little bit more what's in there. But from the start, we really started with focus groups, which to me was and is just scratching the surface, right? In terms of how we can really integrate community perspectives in even the design of the intervention. So this was the starting point, I guess, is what I really want to identify. Because even after doing the focus groups, we have included youth co-designers and parent care designers, caregiver designers, as we're designing the features and content of the app. But in the first order, in terms of looking at focus groups, we looked at current high school students and recent graduates from Southern California Bay Area, included them in focus groups to think about, what we really might need on this app. And the protocol included student-reported stressors. We talked about, please tell us about some of the stresses and worries that high school students experience, about what are the available mental health supports in schools and community, what would be the use of a mental health app. We looked at connected app demo and suggestions for app content, how it needed to be implemented, what would be helpful or not. And we coded these for qualitative analysis. And the youth had some prioritized themes around high school stressors. They really talked about academic stress and burnout, and also these issues around stress related to identity and culture. You've talked about the importance of needing to address themes in any intervention around racial, ethnic discrimination, discrimination based on gender, and LGBTQIA+ pressures, pressures for first-generation students, othering for immigrant youth, and documentation status, stressors that seemed familiar to me from the past research, and it was very important for me to see that those were things that they felt were really important to include. Family stress was also things that they brought: acculturation stress, bullying, isolation. Again, this idea of isolation versus belonging, and how COVID had added to that toll, and the issues of relationships. Students, both the current high school students and recent grads, name mental health conditions of anxiety and depression as critical to address, but primarily describe stressful events or situations. So for example, we then developed pathways within the app, including the academic stress pathway, which was built using stories from the students' narratives, as well as sort of other youth that joined us as ongoing app co-designers. Academic content was identified by students, and we also sort of created tips with them in terms of how to time management, strategies for first generation students, which was a very significant theme, and how to sort of do self-care and self-wellness in terms of meditation for focus and attention and understanding learning differences. But other phase one takeaways for the implementation that was very critical and important for us is that youth felt the app had to be anonymous, private and secure, self-directed, and culturally responsive. They had to be able to use this app without being monitored, and that it had to have cultural salience to a lot of these themes that we talked about. They also felt that the parent role version of it most definitely needed to have a component around parents or caregivers understanding mental health and activation around seeking additional support if needed, and engagement and support around social determinants. There's an emphasis on prevention and not illness, more strength-based, and how to support youth rather than focusing only on diagnosis and disorder. And the app does have sort of local resources for how to address social determinants. And again, this focus on academic pressures. And so the way that we're really trying to work on the co-design of this intervention app, which is now called Connected for Wellness, again, through co-design and making decisions about even the name of the app. We're integrating this input and co-design from youth and adult co-developers. We're looking at lessons learned from other interventions, digital interventions that some of our colleagues, the ones that were involved in the duethnography, myself, of what we've learned from family foster care and juvenile justice navigator studies, because there is a component around, again, the family navigator youth support in using the app, not just using a digital intervention, but having that support and community. And then we're looking at de-identified data from our clinics and our schools and looking at, how the use of this Connected for Wellness app is impacting on wellness services use, access to mental health services and social determinants, and looking at what things might have to be adjusted and developed ongoingly in the app. And then it also has an AI component where the particular use of the individual of the app, even though anonymous, the AI can sort of help guide them to resources that might be most beneficial for them based on how they're responsive in the app. And then also, what is happening in the whole ecosystem that, others like that particular user benefited from, and they might benefit as well. So there's a component like that. This just talks a little bit more about how we're doing that assessment on high school campuses, primary care clinics, and working with navigators and wellness in the wellness app to really sort of do a tiered care intervention options, depending on what is, developing for the particular users around, universal sort of prevention, more targeted or more intensive services, directing the individual to that particular level of care. And this just talks a little bit about, we're looking at children or adolescents age 13 to 22. Peer support is a peer support at schools that is embedded in this, the family navigation, and then the Connected for Wellness app, which is co-designed. And this is just an example of the questionnaire that we added into the app, which is the WHO-5 questionnaire, because again, the schools were a little bit concerned about having PHQ-2 or PHQ-9 any kind of suicide screener on the app because it is anonymous and that's how it was developed. And also youth wanted things that were more on the scale of how well things are going for them, wellness, health. And so the WHO5 questionnaire is one of the primary screeners on the app that, depending on how the youth answers, the app has some responsiveness around things that might help them around, for example, if they are having a low degree of sense of connection and low on the WHO5, sort of options and alternatives for practices of well-being or help seeking. And we're looking at a cascade of care model where we're really looking at, how in the app and with the navigators and support, we increase screening and identification of need, activation of the end users and providers in using the wellness resources, social determinant resources, or seeking additional help, and how well we're matching to services and how well we're doing in terms of initiation, engagement, and care, if or use of resources if those referrals or recommendations are made. This just gives a little bit of an example of the different pathways or pathways of resources that are available in the app for English and Spanish. Anything from sort of, again, the academic stress, emotional regulation, emotion, CBT, and mindfulness. What is mental health? And it's similar for the youth and parent caregivers, but delivered in the particular voice and perspective of the user, end user. Again, this talks a little bit about the check-ins that are in there, the WHO5, looking at sleep, community resources needs, and resources that are available within the app, which include community resources and hotlines. And I won't go into this in too much detail because it's for the sake of time, but it's just sort of, again, sort of framing what has been the approach with community engagement, core principles at the heart, I think, of the intervention. And to be honest, I think I can keep pushing myself more and more in really digging into this idea of community engagement, community partnership. But the core principles are here, right, where we're really trying to create interventions that address these cultural and social determinants of health that are built on trust, that are inclusive, that are culturally centered, that are ongoing, that are co-equal, co-created, that respect the idea of multi-knowledge. And it really, with that core, I think there's really an opportunity for thriving communities where we're really creating community capacity and connectivity, improving and aligning our solutions to actionable, implementable with the community, expanding our knowledge bidirectionally, and community-ready information, and strengthening partnerships and alliances with community members so that we can really build on this shared power, this trust, this mutual value that can, hopefully move us more towards the direction of health equity, right, and transforming systems for health. So in this sort of towards the end of my presentation here, I want to talk a little bit about a project that's just initiating that I think is really pushing it even more forward for me, at least, in terms of how to do this really community, not only partnered, but community-led research. And so I'll start here with the Somos Esenciales. So I was in San Francisco before here, being in UC Riverside for 4 years, where I was the chief of psychiatry at San Francisco General Hospital, vice chair for psychiatry for UCSF. And San Francisco General Hospital is embedded within the Mission District of San Francisco, which is a historically Latino, Latinx, and Native American historical district and community. And the Somos Esenciales are a group of mostly essential workers who started to work at what became the Mission Food Hub, a center of food for the community that was very economically devastated by the pandemic, where they came to work at the Mission Hub to be able to provide food for the community. And you can see pictures here of them giving boxes of food. And they would come in, almost on a daily basis and take shifts in working. And this was a project that was led by Roberta Hernandez, who's there on the right. And a message that really came out through that process, like, for example, with Carmela Gomez, 61 in Spanish, said, her photos there on the left, that this whole process of feeding the community, of being there, of serving, it serves as a form of therapy for me. And it became very clear to them that being able to sort of make an impact on the needs of their community with culturally appropriate food, they would play music, they started to create, sort of really cultural healing. Connie, who's in the middle there providing food, identifies as Mayan, as well as Latina, and is indigenous healing dancer. And all of these things started to emerge. And then they created their own participatory action research group, where they actually started to research what is happening in the community with COVID-19. Well, how has it impacted our community at all different levels? And this is where they became the Somos Esenciales, or we are essential, the essential researchers. And these are the 15 originally, including Paul Flores, who's an artist, who brought together these essential workers in this participatory action research framed through funding, and Adriana Camarena, who was a facilitator. And really, it was not something that really centered around nothing about us or for us without us. And the Somos Esenciales actually called upon me as chief of psychiatry to come and hear their presentations about their research findings. So this was the first time that I really engaged in research that was not just me sort of creating a study and then finding people to participate, but the participatory researchers found me. And they really researched things from a sense of asking questions about shared experiences, and their methodology that was trained to them by the Southwest Folklife Alliance, was this folk life-based participatory action research, where there is this centering around socially engaged knowledge, that the community has knowledge that is built through social networks, that the community has traditional knowledge, ways of knowing and being that usually are passed down orally from one generation to the next, and that the community has ways of learning and teaching that is grounded in community members' participation, and that you can use this sort of cultural knowledge and wisdom in your knowledge seeking, right? And in your ideas about thinking about solutions. So they asked a lot of questions of their community members around, what was the impact, how were they affected, and also what did they do to maintain their wellness? And they really identified mental health as some of the primary ways that the pandemic impacted them. Mental health came up as one of the number one, if not the number one, negative impact. And so they looked into that, and they also talked about, in what ways mental health was impacted, but also ways that they could do wellness. And this is everything from sort of dancing, cooking together, volunteering, like at the Mission Hub, talking to friends, deshogar, which is this real sense of, having an opportunity to talk and be heard about what our experiences have been, gardening, and then also, even low riding. So low riders working on cars, which is, a thing very much in Latino Mexican culture and Southern California. There was even a creation of a men's low riding group to talk about mental health and support. So the critical thing here was there was this idea of creating community's own solutions. And so their recommendations in the end was really they wanted to establish a cultural center for mental health, which they are, obtain fundings for their own solutions for mental health and their support for research done by, for, and about their community. I have, been privileged to be able to sort of engage with that in, providing additional funding in looking at the impact of long COVID, where the researchers in the community are leading that research. And in addition, here's an example of where we, with the funding that we were able to give them through UCSF, they created the next level of Somos Esenciales, which includes Somos Remedios. We are the healing, essentially. We are the remedies, where they looked at the ongoing impact of long COVID symptoms, both like physical and mental health, behavioral health consequences of the severe degree of COVID impact in the community and in the central immigrant worker community. And they identified several symptoms that people are ongoing and created, for example, La Loteria del COVID, which is sort of this bingo card that you can see on the lower right there, where they worked with the community around, identifying these different things that might be related to long COVID, but also, what are some of the things that people could lean into in terms of social supports and cultural healing, that foods, anti-inflammatory foods that are at the root of the cultures, and how can that sort of help around healing that's in our roots, which is what you see on the left there. La sanación está en nuestras raíces. And they had this event where you see us here talking about long COVID and healing and what their findings were. And they provided a lunch or a dinner that was culturally based, healthy foods that can help in terms of promoting wellness. And they also created this report that really talks about the sequelae of COVID and long COVID, and the impact on the Latino community in San Francisco, and ways that those can be managed, as well as changes that have to happen into interactions with healthcare. So they wanted additional funding, and this is, and in this good news is that NIH, National Institute of Health, created these community partnerships to advance science for society programs, call for proposals. And the goals of the Compass are to develop and share and evaluate community-led health equity structural interventions that leverage partnerships across multiple sectors to reduce health disparities, and to develop a new health equity research model for community-led, multi-sectoral structural intervention research across NIH and other federal agencies. And based on the work that Somos Esenciales was doing, Roberto Hernandez was doing at the Mission Hub, I thought that they would be fabulous to apply for this. And I was, would be privileged to be their academic partner. And they applied and they were awarded in this past September. And the research project that they are now leading as principal investigators is the Somos Esenciales Community Revitalization and Health through Latino Arts and Entrepreneurship. And this is a collaboration with Cultura y Alternativa de las Americas, which runs a lot of the arts activities and Carnival in San Francisco, and Friendship House, which is a Native American-led community-based organization, and working together with the Latinx immigrant essential worker labor force, Native American, Black communities in the Bay Area to do this project that's really looking at community revitalization. The proposed multi-dimensional intervention is really focused on increasing that social capital, cultural resources, coalitions, networks, and it's centered around a village healing center which you've seen the entrance to that. That I was just there last weekend, and that's going to be open in about a couple of months, where there is this real healing center where culturally based healing practices are going to be provided and offered, and education around cultural centered healing and wellness. And also work with promoters that are going to be working around supporting with funding from the city around increased home ownership, entrepreneurship, and urban farming with the community. And we're really going to be looking at, how this reduces chronic and stress-related physical and mental health problems and population individual level data outcomes over 5 years initially, and then the study may go on for 10 years. And, here is an example of sort of the way that the Somos Esenciales is disseminating their work. You see Connie here again, and they were recently in the KQED, really looking at sort of showing through theater is one of the ways that they demonstrated the narratives that they were experiencing in their research. They created these theatrical pieces that really demonstrated what their data was showing in terms of themes, and also looking at the ways that they're finding healing. And this was featured in a KQED or public television. So some of the conclusions, what I would say, it's, this is a very sort of broad sort of summary of this, and I look forward to sort of our questions or discussions, but the real importance of incorporating community partnerships, and I would say community-led in our clinical practice and research, especially when we're trying to look at these structural cultural models for understanding and addressing mental health inequities. I think the future of community-based research in mental health, if we're really going to transform disparities, really requires a significant paradigm shift. And, in my presentation today, I'll have to say that, this has been, a journey for myself as well. Even being, Latina, being trained in health services research, being a physician, having, significant mentors throughout my life course career, like Margarita Alegría, who's at Harvard, who's, was the principal investigator of that National Latino and Asian American study that I was describing earlier. This real sort of movement to community trust, and I would say it's community trust mutually, in terms of them trusting me as a researcher and me trusting the community to hold the research and the power of decision-making around research, and leading the research now with this Compass grant. I think if we can continue to sort of support these types of initiatives in both our research and in our strivings to make some changes for communities as even clinicians, it really is this paradigm shift in power and how do we collaborate. So I'll end there because I think we're almost at the hour, and I think we might have some questions.